everyone has come back. Hope you had a great discussion. Let's do kind of a quick report out, hear from your facilitators what the some of the real key points that you shared. We'll start with Kate and your group.
Yeah, we basically talked about the lack of a dissemination plan and trying to understand, kind of what was expected to be done with the information that was gathered. That looked like there were some barriers to gathering information and to, how that was going to be utilized.
Thanks a lot, Kate.
Especially for dissemination.
Yeah, absolutely. Yeah, really good points there. Tuato, would you like to go?
Yeah, sure. So in our group, we kind of expanded on the conversation about like kind of the trust and mistrust and communications between patients and researchers. So we were talking a little bit about clinical trial diversity, and a really good point that was brought up is like, what is the purpose of doing it if doing all this if it's not well deserved? And little things that can be improved are things like maybe like getting the trial reporting data delivered on time and kind of giving patients that transparency on why are things changing. And then we also talked a lot about the barriers that might stop having these better engagements, which could just be like there's sometimes disconnect between those at the top and those who are doing the recruiting, which I thought was really interesting. And also just when we do have these patient advisors, sometimes there's limitations on what people can do and what they can't do, and having to mitigate that.
Great. It's a great summary. Thanks so much. Good points. Jody Ann?
Yes, my group spoke a lot towards the transparency of the process. So not really disclosing how groups were selected for this type of research, really going about it in an influencer strategy mechanism in which an influencer from a certain advocacy group was selected to recruit their demographic, and really excluding many of the different racial backgrounds that make up the diverse composition of America, many of those being left out because they were never included in the dissemination partner strategy, as well as looking to how data is maintained for these long-term trials. Really getting into, is it always relevant to the participants, the data that's being collected, and how could that be improved from the patient perspective?
Great. Thanks, Jody Ann. Some other good points there. And Gabe, what did your group talk about?
Yeah, so my group also said about, or was saying about the same thing that a lot of other groups were stating, just having a lack of trust in entering information into a public entity like that, without any real feedback on what benefit short term they would get, and that the website was really just research facing. It wasn't inviting to a participant to enter in their information, and there also wasn't a clear dissemination plan on how the information will get back to the participants. So a lot what everybody else was saying when it comes to the program.
No, it's great. I mean, it's a great summary, and there are some changes happening with all of this site, but as it stands now, some really good analysis from the group.
Much of today's discussion really has talked about overcoming barriers to dissemination. And while, our panelists have been prepared for, leading this discussion, I really actually want to, as Hala mentioned, really flip the script and have our participants sort of share either again from their experiences prior to today's conference or some reactions that they've had to today's conversations. Like what are the barriers to dissemination, either the ones that are really the high level, or again, what we haven't discussed yet that we really need to in order to ensure, that we overcome, these when we go back to our organizations and our communities. I just, again, want to hear from the participants first, and then get the reactions from the panelists to what people are taking away from today's conversations.
One big takeaway that I'm getting from this conversation that we're having actually is trust, and I definitely do feel like trust takes some time depending on your end users or audience. it really takes some time, and I really speak to a lot because I myself as a patient have barriers, through that experience of trusting researchers or professionals who can definitely provide a better experience for me when participating in clinical trials or really just going to a doctor's visit. So it really takes time and also builds a lot of cultural competency. Just because someone's competitive doesn't mean that they are reliable or doesn't mean that they can be trusted, but it takes some time to build trust. And also, I do want to touch on accessibility a little bit. That really brings a lot of key element or importance here to really build that trust among communities and also patients as well. So yeah, so building trust really takes some time. And I think that the main barrier with that is really taking into account of some of these researchers or professionals to how to better effectively communicate, especially when it comes to research findings from studies as well, to better communicate with their participants in order to continue on to build that trust. Yeah, so I just want to take away from that.
Thanks, Brian. And before you leave the hot seat, I do have a follow-up question for you. So imagine there's a researcher from a local institution who, right, is just starting on their journey, right? And so you say it takes a long time. They say, Brian, like, how do I do this? What advice would you give them?
Absolutely. I think the best advice I can definitely provide for them is really to be very transparent about this process. For example, going over with me the overview of a research study proposal or project or a clinical trial before giving my consent, and also really explain more in detail about the informed consent procedures. That's really, really important because that speaks a lot to what you're expected in a clinical trial or a research project, right? So they have to be very transparent through communicating through the informed consent and also the overview of a clinical trial or research project.
Thanks, Brian. And then I see Jeff and then Jen. Jeff, what are your thoughts?
Okay. Really reinforcing what Brian was saying about communication and speaking the language. And an example I was kind of struggling with of how to explain it was medical literature. And we just had something published, and it took me a couple of weeks to read the whole thing, even though I knew what it was about. But it's so precise and it's focused like a laser. But as a patient, that doesn't help me. I need to see a little bit more. So I need more of a flashlight so I can have a broader look at it. But the spotlight, that's what we're doing. We're kind of the translators between the medical community and the patients that don't know anything but their disease and what am I going to do? How do I answer those questions? So we're trying to shine the spotlight, kind of a medium between, the laser focus, the hot 22nd, 23rd grade level, reading level. And I really want to get away from the idea of reading levels to being accessible. And for some reason, it just seems pejorative to me to say, well, take it down to a 6th grade reading level. Dumb it down. That's what it sounds like. And I really want to make it more accessible, or and I like that idea of the laser focus versus the flashlight versus the spotlight. And that's what we are. We're the show.
Yeah, here is a really good point that I don't think has been part of just the general conversation of how we discuss language. And Brian mentioned this in a couple of his comments earlier, that instead of talking about a specific grade level, right? How do we create language around language, right? Inclusive language, accessible language, not using jargon. So that's a really good point, and something that I don't know that all of the toolkits necessarily address. But Jen, what thoughts do you have?
I just wanted to share two things when we're thinking about trust. I mean, I think one thing is that patients and communities want to know that researchers care about them beyond their participation in research or beyond them receiving research findings. And I think that's hard because we act like research institutions and health institutions are separate, but typically they're connected in the same with like health federal health agencies and research agencies. And so when we don't have access to equitable healthcare, that message doesn't feel very trustworthy, that no, we care a bit about your health beyond participating in research. And I think, related to the question that you posed recently, Hillary, around, what should research keep in mind, is that researchers should, always prepare to do research. They do their academic literature review, all this, but they don't always prepare to partner in terms of like show communities, patients the same respect by, learning about history, what's already happening, what's going on, in communities, being present, being a part of it.
Language is important to me, and what Jeff was saying is also important to me, because not just being a patient, before my trauma, that was my role in terms of working with patients as a speech language pathologist. And so not necessarily focused on grade level, but making information that's being presented to my patients understandable to them, and working at where they're at, and understanding that language is not, language involves many things. It involves social language, and cultural language, and so that it's not a standardized 6th grade reading level type when we address it.
Thanks so much, Deborah. And that speaks to what Gerard's question was right before we went to break. So, keep using the chat. If you have additional thoughts, raise your hand. But Gerard, is this getting to sort of what you posed before we went on break? Do you have any sort of that we can ask the group? What are you thinking as you're hearing these responses come in?
Yeah, it was great. I went to that breakout room, and they're touching upon it. It's understanding, outside of whatever your product is, whatever you're doing, what's the point? The barrier is the point, and the reason why they're not getting to the point, and a lot of these products, are not as effective as they can be, is because they've never partnered with the community that they're working with. They never got the necessary insights or the buy-in to actually execute in the first place. So whatever preconceived notions that someone may have, or even if they have no initial bias, it's very hard to move forward when you don't have a level of partnership or buy-in with who you're working with. That seems like the overall tone of the barriers that were occurring. So it was very helpful. And yes, my question was answered.
Well, certainly, I'm sure there are other perspectives too, and people can share sort of in response to your prompt. I do want to point to some really good conversation in the chat. So Tennille agreed with Jen, as do many people with the thumbs up that I'm seeing. And Tennille said, participants are tired of having researchers and health professionals ask about their health-related social needs with no intention of helping to remedy them or directing to appropriate resources to assist. So would love to hear from the group. How do we remedy that barrier? If we're talking about trust, we're talking about sustainable relationships and about trusting the communication that comes out from, again, our various institutions or research projects. Sort of thoughts, and especially if, I could say, a researcher would say, well, I don't have money. I don't have money to provide those resources. So what are some reactions from the group about the health-related social needs and what goes beyond being a participant in a trial?
Yeah, this is something, or at least an aspect of, I guess, the greater point that you made that I've struggled with, especially during my time recruiting patients for studies. So much my mindset was effectively, okay, identify patients that is eligible for study X, approach them and try and get them to agree to participate in study X, follow them for the length of time needed, and then move on to the next. right? And this is, I guess, a mindset that I think really needs to be shifted. And it was so much just kind of like identify them, get them in, get them out, and then move on to the next. And that kind of goes back to the whole topic of even ongoing dissemination that I struggle with as well, where in my mind, so much of, I guess, what we do as researchers is, okay, we completed this study, we got it published in a major medical journal. Now, what's the next project? Let's move on to the next project. We always have an eye on the future, and that the idea of maybe this ongoing dissemination, I guess, really eludes me to a degree, because I'm so focused on, okay, well, this project's now done. We accomplished effectively what we set out to do in executing it, but now there's another project starting. So, okay, see you later. You're published. Let's move on to the next one. Now let's try to get this one done and published. So trying to shift away from that is something that I really struggle with, frankly, and I wouldn't be surprised if others do as well, because I do feel a degree of this is kind of, passed down, really from the institution itself and those people who are, running these studies down to those of us who are executing it.
Thanks so much, Jordan, for sharing. And before I let you off the hot seat, I do have a question, right? It's something you've said you've struggled with. Have you found solutions? What are some suggestions that you might have for others who find themselves in a similar situation?
What I would say is participating in discussions like today are really a great starting point. I see that there's, I guess, 37 of us participating today. I think that today's topics are relevant for, I guess, such a broader amount of people, who are engaged at all in clinical research. So I think that's something that having these discussions is really a great starting point. Now, whether it's in conferences like this or within your own teams at your office, it's certainly something that I would advocate for moving forward.
Thanks, Jordan. Right. And I mean, discussion is always good. And hopefully at the end of, this session, and certainly at the end of our third session for today, where we're doing the toolkit evaluation, there are tools that each of you can take back to your communities and your organizations to continue the conversations and come up with resources to move this work forward. Tracy, what considerations do you have?
So I don't have any answers, but I was just wondering if it's possible, if you don't have money in the budget for a particular project, if you're talking about always looking ahead, then maybe that's something worth considering for a future commitment. We don't have it in the budget today. However, down the road, we're phase 2 of our project might entail this, and perhaps there could be some room to build something in that's desirable in the next phase. And then also one thing I learned through the Patient Professor Academy was listening to patients say that it's not always some good that they're looking for. It could be a service. It could be something that you don't have to pay for in terms of purchasing, but you may pay in terms of time and commitment, so maybe it's providing a service to the community that's beneficial to them instead of, actually buying them something or paying members to participate.
Thanks, Tracy. And it speaks, one of the threads that I've noticed in the chat today, it talks about a lot of the tools or the prompts, certainly from like the Clear Communication Index, is geared towards systems, right? Whether it's health systems, medical systems, academic researchers. And we are likely one of many people, right, on a campus or at an organization, and those organizations do have resources. So even if it's not the financial resource, it's the resource of knowledge, right? The resource of referrals, of being able to have access to other people who might be able to have the answers that maybe our communities that we're serving and collaborating with, want information on. So I agree. And how do we think more broadly about what we can provide, even if it's not a financial compensation? Other thoughts? Yeah, David.
You're right, Hillary, that it's always incredibly tricky to navigate this, specifically if you don't have the funding to be able to do so. And there's a lot of trials that run with, bare minimum funding to be able to provide to the participants. But I even find certain things like just the thank you, thank you so much for participating. You don't know how much this actually means to us. Can really change someone's day and really make them feel appreciated for being in the trial. Some of the concepts we discussed earlier as well, like making sure that they're one of the first people to get the results of the trial when it's complete is something that people should be prioritizing if they're indeed interested in that. But just little things like that, sending an appreciation thank you card, sending even if it's a small gift of $5 or $10 or covering the parking costs associated with any visits that they have to do. They're not big, they're not, huge financial incentives, but little things like that do make people feel appreciated for their time.
Thanks. Brian, and then Hala, and then I'll also open it up to our other panelists and advisors on sort of their reactions. So Brian, what are you thinking?
Thank you, Hillary. Just real quick, and there's one term that I'm thinking right now, and it's called connecting to the bridge. What that means is that when a research study does not get adequately funded for some reason, it's always best to connect the participants to another network or organization to be able to have that participation, just making feel them that they're valid and they're being heard. Because at the end of the day, we just don't want no harm, right? Do no harm. So we want to connect them to other supports and networks in order to participate in those clinical trials that are more adequately funded and not leaving them behind. So that's something that I want to add.
Thanks, Brian. Hala?
Yeah, I just wanted to go back to the notion of funding and asking about social needs and not being able to address them. I mean, I think one of the biggest untapped resources and partnerships that institutions lack is connections to community health workers and community-based organizations. And certainly on projects that I've been on, where we're looking at healthcare transformation, this is a big lever that we focus on. And so it's incumbent kind of upon institutions and researchers before they begin other processes to really look to those partners. And if you are specifically talking about a social need that is being addressed in the community by CHWs or CBOs, then connect with them. That should be part of your process. Because certainly, patients and families, members and caregivers don't, when they feel like, okay, you're asking me all these questions, but you're not addressing any of them. You're asking me to give blood. You're asking me to come in for XYZ. But then what is it I'm really getting in return that helps support me in my healthcare journey, in my own life, my own quality of life? And so I think that this is all part of the processes. And I think that's where I go back to my initial comment around education and training. I've done confidential subject matter expert interviews of researchers as to why they don't necessarily go into community. And the very honest answer I've gotten is we haven't gotten the training and we're not comfortable. And so we need to take a few steps back and look at our education apparatus and how are we training future researchers in community-based or community participatory research? How are we training our medical students? And so that starts also, pushing us to think, who's teaching and why aren't those opportunities being offered to the community? Why aren't we supporting them in their own education to become professors and faculty, not just speaking at a ground rounds, not just coming in one day and sharing a story, but actually being full-time faculty tenured? That's really where we need to go. And we need to design training programs for our current and our future researchers and clinicians to really address a lot of these issues.
Thanks so much, Hala. I see a lot of head nods in agreement. And so certainly if there are others who want to chime in to some of the prompts that Hala mentioned, again, those are some calls to action for organizations. Gerard, would love to hear your thoughts. And then I also want to ask Cynthia to talk about her experiences of working with community health workers in your groups to bridge the community research. But Gerard, first, reactions.
No, it's one of the few barriers that's spoke of, but it's very high in research, is the fact that most PIs, 93% of PIs are usually not representative or reflective of the people that they're serving. And that's a huge issue because the relatability, the understanding, the shared connection to community is just not there. And of course, there has to be more. If for instance, how should I say? So my mother was a nurse, right? So I was at a very early age, I was exposed to healthcare and the benefits and some of the downfalls and, you know, some of the pitfalls that occur there. So and she also worked in a community clinic. So I was able to experience at a very early age, not only professionals, but the entire ecosystem that actually looked like me. And when you don't have that in the training, in the actual people who are actually delivering that, the propensity for you to actually grow and actually even have an interest in these type of fields is very low. I mean, it's a perfect example. There's a funny thing that we always say, if, you know, tell me who your friends are, I'll tell you who you are. So if I got 10 friends who are bums, you're probably a bum too, right? So it's the same thing. If I have 10 people who are interested in my community that have partnered, who are, like you said, the community health workers. We're running a program right now in one of the counties that we work in with community health workers. And it's been outstanding because you're getting more participation solely because they can relate to the people that they're working with. So that's something that is often not discussed. And I think that if you start involving the community, then actually, and there's an interest and there's a need, you know, the need is highlighted, then you would actually get more funding and actually more training for these people to actually grow.
Thanks, Gerard. And thanks for sharing, again, real life examples. Again, we all have these experiences being in the community or facing challenges. And so I just, again, want to thank everyone for being open and honest in today's conversations. Cynthia, you know, one, can you talk a little bit about how you've had community health workers incorporated into the development of the work that you've done, but then also too, right? We've drifted a little bit away from dissemination only, right? We're talking about really big themes about continuous engagement and relationship building and trust with community partnership. And so, you know, how do we also like bring it back to dissemination at large? And again, recognizing dissemination is just not that single point, right? All of the work that we're talking about here of building relationships, giving first rather than just giving back to the community are all part of those efforts. So Cynthia, what is the method to our approaches?
I'll try and keep it short. So I'll give you two examples. One, we wanted to build a smartphone application for English-speaking Black adults and Spanish-speaking Latino adults. And so we went to community health workers first because community health workers work with many people in the community that are interested. And so we vetted the idea with them first, and we continued to talk to them over time. We built prototypes with them, and we tried those prototypes with them. So they were on the prototype teams. And then when we wanted to try and reach out, then the community health workers were already very familiar with the project, right? So when we asked this one community health worker in particular to help with some outreach, she was already very comfortable with the team and knew what we were doing. So that was one example. We've been working in one town here in Maryland with a community-based organization that came to us and asked us to partner with them on the project. And it's an organization of community health workers. And they wanted to work in 9 languages. So this project happens concurrently in 9 languages. And one of the community health workers on the partner side, I had a conversation with the executive director of the organization, and we decided that community health worker would switch sides of the project fence. So she switched over to our budget and we pay her, and she's part of the university side team, but she works back, I mean, across all parts of the project. And so a lot of times what's been super valuable is that the other community health workers will call her directly, and that's how information comes back into our team. And so she's been on there pretty much from our team from the beginning. And I don't think we could have done this project if she hadn't been on our side of the fence. So that's a couple of quick examples.
Thanks, Cynthia. We're going to go in the next minute or two into our breakouts to discuss the toolkits that you each received prior to today's session, and some of the things that we've discussed today. But again, as we wrap up our discussion on, overcoming barriers to dissemination, or overcoming barriers to trust, or overcoming barriers to sustainable partnerships with community-based organizations and community members, any sort of thoughts from the group? People, especially who haven't had a chance to share something yet today?
A lot of conversation today is really focused on, hospitals, universities, research enterprises as barriers, right? I mean, that's kind of been a subtext. The only reason I think that it matters that they still stay part of this conversation, even while focusing on the partnership that has to happen, is they sit on the resources. And that's why I remain interested in them. And I haven't thrown up my hands entirely, is that you think about that's where the resources sit. And so I think if we want to pry open the process to get access to some resources, we have to kind of figure out how to have this conversation. I think, I forget who it was who said that, but internally, right? It has to happen within a lot of organizations simultaneously. Professional societies have to get involved. So don't give up on the professionals entirely. They may not be as aware and informed and ready for change as many of the patients need them to be. And I mean, I totally, I'm a consumer advocate myself, so I totally get that. But at the same time, I recognize that we need to have the laws, the policies, the resources to get some of the changes that we want. So, I would just say, like, as you think about the toolkits, think about which ones will help you most try and maximize the resources that you need for the kind of dissemination work that you think should happen.
Thanks, Cynthia. Eileen?
That I had, I was hearing a lot about, actually doing something to solve the problem and providing that value. And if you don't have the funding, one of the questions that I think about is, well, what can you do? What do you have? And instead of, I don't have this, I don't have that, I don't have this, what do you have? How can you help? What value can you provide? And I think when it's coming from that place of, I'm not trying to get something from you, I'm trying to give something to you, and not just give something to you, but give something that can actually help you because you said this is what you need that can help you. And I think that makes a difference. And I don't want to go too much in the dissemination chat because we're getting ready to have this discussion on the different dissemination toolkits, but I think that's a valuable piece in really hearing the person, hearing what they need, meeting them where they are, but then also saying, okay, here's what I can actually do to help at this moment. This is what I can actually do. People value that. And I value it. I mean, it's valuable to me when I hear somebody say, I can help you, I can meet you right here. And if you need additional assistance, this is what I can do. Or I can connect you. I can find ways to help you to get to where you want to go, not just for me to solve my problem. I want to help you and really make you a priority. And so, this discussion is awesome.
Thanks, Eileen. Yeah, and I echo what Hala said in the chat, which is starting from a place of strength and abundance and meeting people where they're at. So absolutely, right? We all can have things to give. And I also want to mention something that Janice said earlier on in the chat, which was asking for what people need. And so I don't know, Janice, if you want to chime in sort of about some of your experiences, right, in this this giving, what thoughts do you have? Yeah.
Sure. So, fortunately, during a tough time during COVID, the county I live in our state really decided to invest their dollars in the community. I mean, there was a lot of philanthropic dollars running around nationally, and not all of it is accounted for, unfortunately, but we really did see it invested in our community locally. And quite a few put their dollars where their handshake was, and invested in what was developed called the Lived Experience Coalition. And it's a number of individuals, primarily BIPOC individuals, but not only, with lived experiences that have been less than the most desirable, right? We've all had tough times. And so they purposely set out and to apply for positions in governances around the state, right? Now it's gone statewide just last few months, but to encourage people to apply for an advisory position, even, at the governmental level, right? And with like HUD, with housing and healthcare and different levels. And we have, I don't know, maybe 20 people now that are serving on committees, higher level committees, which is a first step, really, and everybody work together in training and skill building. And so that's important. And as you mentioned, what else can you do? They also would assist us with phones or computers or Wi-Fi if that was needed. And I think considering the situation and research, if somebody's actually on a project, they do need Wi-Fi for sure. And if you're covering that, if you can help with that, that's huge, as well as even a smartphone. It doesn't have to be a super expensive one, but it is one that they could communicate if they don't have a computer. And it could be other access, like, they could be hearing, there could be hearing or sight challenges. So to ensure that they're able to have their needs met by even like transcripts, I saw we have here, sometimes they don't have that if, you have hearing issues. I was on a call yesterday, they didn't have it. So that's really important. So finding out before meetings, actually, what might be needed, and also like caregiving and, is super important, transportation. But I think if it's virtual and things today, it's just asking them what they need. They did ask us this before meetings, and it was really important, and we appreciated it. Thank you.
Thanks, Janice. And Jen just put something in the chat really about our discussions on power. So Jen, do you want to sort of share and explain a little bit about some of the power dynamics that you're talking about, or some of the resources that can help, again, like all members of this P-Core workforce community address it more meaningfully? Because again, as much as we can talk about it, are we actually making change? But would love to hear some of your perspective on that.
Yeah, just building on what people are saying about, community leadership and in these issues. And I think that there's more understanding of the connection between power and concepts of power and this type of collaboration. And I found there's a few webinars and toolkits that Human Impact Partners has that have helped me kind of think more about how we move from this idea of power being finite, needing to hoard or protect it, to conceptions of, again, like the abundance consciousness and power with, and it's really infinite and it expands when it's shared with others, and that it's a really necessary to have transformation of what we see as limitations, but we have the ability to collectively work towards what we want. I'll put a link to their website in the chat.
Great, thanks, Jen. And so with that, we are going to move to our final breakout session for the day. And this is the toolkit evaluation discussion. So again, each of you had an opportunity to review 3 toolkits, and we really want you to go into these discussions again, similar to the framework that we've had for the early ones, like what works, what doesn't work. I've really appreciated how participants today have said, like, this is the thing that's missing from this tool or this guidance document. And, if issues of like power or transparency or other models that we've talked about today aren't represented in those toolkits, we would love to get your feedback so we can figure out, if these tools aren't sufficient, how do we create the new tool, or how do we revise it so that it can actually meet these needs in a more transparent, equitable, and empowering for all way.
So go ahead with the report out. We'll go to Jody Ann, if you'd like to share some of the big points that came out of your discussion.
Yeah, absolutely. So we had a really good discussion talking a lot about the different toolkits and how they might come off to the person who's using them. So we also had the graphic designer provide their perspective of how sometimes things in a textual framework, it wants to be put into a graphic, and that really starts to become a little confusing because the textual part is confusing. So now it waters down the graphic and sometimes leaves out information. So really getting back to the original message and making sure that that's clear for audiences, and also not really relying heavily on graphics. Sometimes it is important to still convey your message culturally appropriately and not really use too many graphics to water down your message. And we also talked about some of the issues with these toolkits not really reaching their specific audience. So it really was mentioned that the patients program toolkit hasn't really been utilized within the spaces of people who are using different toolkits. So what is the dissemination plan for these toolkits, as well as bringing more transparency to the people who created these toolkits and what contributions they have to the authorship of these toolkits is what we discussed.
Great, Jody. Yeah, some great points started off. Tuado?
Yeah, so our group also talked to a lot about some similar things that Jody's group talked about. We really had a deep discussion about kind of the coloring, and we had mentioned that sometimes the colors not being consistent can really cause things to kind of get lost in translation and can make things difficult. So we're opting not necessarily not bright colors, but maybe softer like pastel colors, and keeping those colors consistent throughout. Also being mindful about wording, just because sometimes just because somebody might not understand this aspect doesn't really speak on their like education level. So just being mindful about that. And then just also some ways that like this toolkit kind of was useful was just that now there's like at least a framework to kind of go by, and to have these conversations that might not have been previously explored before.
Great. Yeah, absolutely. Gabe?
Yeah, so my group really discussed a lot of the same points that Tuado and Jody talked about. We also talked about the length of some of the dissemination toolkits, how long they were, how that could be off-putting to some of people that were reading about reading the toolkit, the usefulness of the worksheets. I did hear a lot of different viewpoints. Some people liked the graphics, some people didn't like the graphics, and some people thought they took away from the information. Some people thought that it really made it not, that like some of the graphics didn't make the information as clear and to the point. So there was a lot of differing opinions on the toolkit.
Great, that's good. It's some difference of opinion. And then Eileen.
Yes, we had similar conversation as well. One of the things that was brought up was ongoing evaluation process. So what will happen after certain points or at certain points, being able to talk about that. And then some of the language within, or even just the title, for the MRCT toolkit, it was good for one audience, but not for the audience that it could have been intended for. So the title wasn't as plain language, and it could have been confusing and very difficult or frustrating to even explore because it was complicated to understand the title. So some of the other pieces were, of course, being able to think about language, how you convey the information, but then also what are the basic things that need to be discussed, and not trying to talk about too much and make it too complex. Then being able to provide some sort of training for clinicians to help them to understand or think about how to share information at different parts of the process, the research process, and what incentives there are for clinicians and or even for the community for being a part of the research. Like they'll be able to get these research results or be able to find out more about what's going on with the research. Another point was ADA accessibility, making sure that they are included in that, and making sure that other individuals are able to actually read it and understand it and process it the way that they need it. And then I think one of the last pieces that I wrote was just not trying to share too much.
Yeah.
So, yeah.
Great. No, thank you so much. So with that, I'm going to launch a poll, and you give your evaluation of which one that you like the best, or if you didn't think any of them were that good. But we're curious to hear what you think about the individual ones.
I would love to hear from people, those who, again, picked the MRCT, maybe someone who picked the Patients Program Dissemination Toolkit development, and then also a couple people said, I didn't like any of them. So would love to hear, one or two people from each, sort of why you selected the toolkit that you did, and getting the conversation going. So is anyone who picked the MRCT as their toolkit of choice want to share what the strengths were? Yeah, Jeff.
I picked it, and it might have been for a very personal reason. It speaks to returning results to the persons in the study, and that's something that there is a big roadblock, and it comes from a valued name that will bolster my arguments to make a change. Because so many research protocols say we will not contact the subjects following the completion of research. And first of all, I don't like using the word subjects, and returning results, is the exact opposite of that. But it's gotten to be the practice for so long.
Jeff, anyone else want to chime in on the MRCT toolkit? Nikhil?
Yeah, so even in my geography, like even in my country, like there's not a practice of telling patients what happened with the trial or the research they participated in. And I think like MRCT is like a good starting point. Like it might not be very like good in all the aspects, but it's like a good starting point to tell clinicians that, these kinds of things, like there are these kinds of things that you have to do. And, it might not be too much, or too much of a burden for them. Like they might be more, more willing to, go into it if they have, certain sets of principles, and they might be more willing to try it in their own way. And then later on, like when to develop a culture, right? And when that initial culture is then maybe we can go into details and follow a more, developed and more, detailed roadmap. Yeah. So for that reason, like I thought it's a good, it's a good starting point for me to discuss with, my clinicians that, okay, we want these kinds of things. We want these kinds of summaries, and could you like work with us to, do these things? Yeah.
Yeah, thanks so much, Nikhil. And thanks, Jeff. Certainly, we've heard throughout today's discussion the importance of returning results to the people who made the trial or the research happen in the first place before thinking about those broader audiences. I am going to put in the chat a couple of the questions that we had used in our guide, which again talked about like who the primary audience or primary user is, what would encourage or prevent colleagues from using this tool, could a wide variety use it? And so, and I've heard this in other sort of convenings where we've talked about tools or rubrics, is that one size fits none. And I don't know if others have been in conferences where that's been said similarly, but right. So there might be a purpose and a real good use for this tool, but it can't do everything, right? And that's likely the case with any toolkit that we're going through. So I would love to hear from others who, again, didn't select the MRCT, and hear from you, like, what would encourage or prevent your colleagues from using the MRCT tool, and then we'll go to the patients program. So anyone want to chime in on sort of maybe the limitations that they saw specific to this tool?
I think there are many limitations for the MRCT. First, they say use plain language, but the language that they use is not plain. And then also, it's not really, it's very specific in terms of the design, which means that only for clinical trials. So other kinds of research, it's really hard to use it. But also it's very general in terms of the instructions that they provide. Like even provide these principles, it's not that something that I can follow as a researcher or a junior researcher even to help me disseminate the results to the participants. And so, yeah, so that's in regards of the disadvantages. I don't want to step into the others.
Thanks, Asma. Let's talk a little bit about the patient's program dissemination toolkit. So for those who selected that toolkit, what was, again, one of the strengths, and then also, again, what might have been a challenge? Does anyone want to share why they selected that tool?
I am low vision, so even when I make the screen larger, I appreciated the font size, right? I think there could be more added to it, but I liked it as sort of a general overall effort. And when somebody was mentioning some of the thoughts previously before we broke out to this part, they were mentioning about the colors. So the colors didn't bother me, but I expect they could. And how could we mute them, perhaps not necessarily make them pastel, but mute the colors somewhat. Thank you.
Thanks, Janice. Anyone else want to share about the dissemination toolkit? Yes, Brian.
Yes, thanks, Hillary. I just want to make it very, very simple right now. I think one advantage that I actually have observed from the patient's program toolkit is that it's very clear and concise. So it's very straight to the point and straightforward. And it's kind of like more ADA compliance, not very much, but kind of tends to get there a little bit, especially with the visual, objects and stuff. That makes it a little bit easier for someone with the vision impairment. So I kind of want to speak to that. But more overall, it's very clear and concise, and that's something that I definitely do see as an advantage, and also because of some element of the ADA compliance towards someone with the visual impairment that may benefit from visual objects. So just want to bring that up.
Thanks, Brian. What about the third toolkit, the development of a planning tool to guide dissemination? Oh, Olivia, yes, love to hear your thoughts.
I chose this one. I'm not very far into my career. I'm only 2 years out of graduating. So the whole process of dissemination is very overwhelming. It's kind of like, where do you start? And I thought this tool was really good at just breaking it down into baby steps, so it didn't seem as overwhelming. And then kind of just helping you figure out where to start, what to think about.
Thanks, Olivia. Tracy?
I like the patient's program toolkit as well. I like the graphics. I like the way it's broken out. I feel like it's chunks of information that's broken down. I like having like steps, like phases 1, 2, 3, and then the guide for the discussion outlining the who, what, when, where. And I just think it's simplified. It is a little bit busy, but I like the fact that the information is broken down into chunks and highlights areas that you need to focus on. And I also like the at the end where it has just simple, plain language that can be used to help people.
Thanks, Tracy. Lots of people in agreement for different areas in the chat. Asma also mentioned referring to the ARC tool. So does anyone who selected the ARC tool, again, the development of a planning tool to guide dissemination of research results, want to share either the strengths or, again, maybe some of the limitations that you could see for that tool being used for an academic community partnership?
I just like worksheets. I think, worksheets are always helpful. Because I think if you just get kind of statements about things, you know, it's harder to turn it into, you know, action steps. So I like the questions and I like the worksheet format. But several of us talked about the fact that it potentially is dated, you know, the content needs to be updated. It doesn't kind of reflect what came out in 2005, so it probably doesn't reflect all the progression in this area, and that should be, you know, changed.
That's a great point, Cynthia. Brian?
So I, unfortunately, for this as well as many other issues, tend to be a yes to all of the above, but recognize that you know, different tools for different purposes. So you know, MRCT is very narrowly focused on returning results to participants, and I agree with the comments on, you know, the need for the entire field to continue to work on this concept of plain language summaries and understand how to convert technical language to plain language. But I think when we think about the very broad, very diverse, multi-component dissemination strategy and all the different target audiences, you know, in some ways these three tools nicely complement one another as far as providing more detailed, in-depth guidance for some of the subsets of target audience.
Ryan. And then we had a couple of people who said that they didn't like any of them. So if that was you and you want to share either, again, the barriers, or is there an alternate tool that you would throw into the ring that maybe achieves some of the goals that we've talked about in terms of successful dissemination today? Anyone share who said they didn't like them? Yes, Danny.
Well, I'm kind of with Brian. I picked that because there wasn't a choice to say any of them. Like, I'm really curious if anybody's using any of them. And if they are, how's it going? And I'm the person who was advocating for, you know, having a, you know, a learning environment where we're working together to, you know, test this stuff and, you know, see what works where. And, you know, there isn't all, I mean, it's the whole point of this is there's no, you know, everybody's got different brains and, you know, I mean, there's just not, the idea that there's one is to me kind of silly. And, but I have no idea, like, is anybody even using any of these and what's happened? So there.
That's a great point. And certainly if someone on this call, if you have used one of these tools and want to share in the chat some of your experiences, please do. We are getting close to time, so raise your hand now or let us know in our evaluation what else you want to share. I see Hala and Jeff, and then we'll go into our wrap up and adjourn at 3 o'clock today. So Hala, final thoughts from you?
Yeah, I was at the camp of I wouldn't use them, but that doesn't mean there wasn't aspects of each of them I probably, you know, thought would be helpful. I think in general, it was hard to make this comparison because it wasn't comparing apples to apples. Each had a different purpose and certainly each had a different audience. It was very clear the patient's program one probably had patient community input. Therefore, it was designed in such a way, although I wasn't sure from the authorship if that was the case. But in general, you know, I'm in the school of co-design and co-creation. And so how do we really look at these tools in a way to partner with others to make them more robust, more accessible? And like Danny said, you know, I think knowing, you know, getting that information about who's actually using them and what is their, you know, what has been the benefits of it. Sometimes I always think that we need to beta test these toolkits before we actually even launch them. Because I know all of us have participated in toolkits and roadmaps and shared decision-making tools, and then they're released into the, you know, to the world, but we never really know who's actually utilizing and what their experience has been.
That's a great point, Hala. Thanks. Jeff?
The PREPID trial existed before the patient's program roadmap or tool, but it almost perfectly describes what our experience was or what our practice was of engagement and listening and sharing information. So in effect, we've used it and I felt it describes it perfectly, and I think it's very good. I do think a little more editing of the colors, like the first roadmap, the color progression is different than the rest of the document, those kinds of things. So
thanks, Jeff. Yeah, and again, each one of these tools, and I agree, we're not comparing apples to apples because we aren't trying to figure out which one is the best of all. But again, what are the unique opportunities that each one of these tools can have? And again, the questions that we asked that came from the CDC's Clear Communication Index, which also has a worksheet if you want to use it, and you can check it out online. But again, who is the primary user? What is the primary objective? What are the sort of facilitators and barriers for using that particular tool? And could a variety of audiences use it? Or what other criteria would you use? So we encourage you either, if, again, something resonated with you, or you said, I like this tool, but it's missing this thing, being able to work to figure out and bridge that gap for what these tools can do, so then how they can have a meaningful impact on your relationships with community partners and others moving forward. We are almost at time, but Joe and I planned our last part of the session to not actually go for 20 minutes, but really to wrap up today.
Continue to have discussions about the work that you're doing in dissemination, the issues that you have faced, challenges that you've overcome. So there's definitely plenty more engagement that we can do.
Again, wrap up with Janice to give some closing reflections for today. So Janice, any final thoughts from you on today's convening?
I just want to say I really appreciated today, and thank you all for all of your input. And in reality, everything we heard was something to be validated. And I appreciated hearing about empathy and somewhat about a lot about community and how we can incorporate groups that we already have some access to into research from the beginning to the dissemination. I thought it was an interesting concept to think about having dissemination products available at the beginning of a research project that explain what the dissemination is about, and having, of course, different stakeholders, whoever, I don't like that term, but different individuals from different interdisciplines, as well as patient, consumers, community, that are able to provide their input and perhaps, snowball reaching out to their community for bigger and better impact and for relevance. So I think that's about it. And I'm looking forward to hearing, I think that asking our top 3 comments or 3 words about dissemination, I said adaptability, that's understandable. And I don't remember what my 3rd one was now, but anyway, well, I didn't hear a lot about adaptability, but I think that that's something we can do. And so I thought it would be a good idea to ask us again at the end, because we might have really similar words at the end, like flexibility, empathy, and others. So thank you. Oh, here
Thanks,
it is.
Janice.
Accessible.
And here it is.
Yeah.
That's actually a great idea. And so in our follow-up email, we'll include a second Menti poll. So in case your 3 words might have evolved over today's session, would love to see how maybe the word maps might look a little different. But we'll also send that out in our notes, and really appreciate everyone's time. The team will be here to answer questions if you want to stick around. But again, it's 3 p.m. We appreciate everyone's time today. Have a great afternoon and a great weekend, and take care. And we'll be in touch soon.